So we can work with individuals, right? If somebody has a difficulty, in a domain or many domains, I can work with them, right? A person might also have, strengths in many domains. So we've talked about this. But let's talk about what the evidence says around working with an individual for mental health difficulties, a person with autism, I mean. There are lots of manuals out there. There's lots of things you can buy now around treating anxiety in kids with autism. These are just examples. I don't have any conflict of interest with any of them. There's pluses and minuses to them all, okay? What's really interesting is that some of these are manuals that are right on the cover, say they're about autism. Other ones were developed for anybody with an anxiety issue, but have been adapted to support the needs of the person with autism. And I like to talk to clinicians about that often, because I say to them, if somebody comes in and is asking for help, right, you're not looking for that perfect client who fits all of your check marks and is to work with. You're going to adapt what you can do to the person that's in front of you, to their unique needs. If I have somebody who has a reading disability, for example, I might do cognitive therapy with them, but I'm not going to overload them with tons of reading material, right? I'm going to change the way that I work with them. Right? So some of this is about recognizing diversity. You don't need autism-specific things to help somebody who has a certain social communicative or learning profile. They might help because they already have thought about how to scaffold learning and development best. So what's the effectiveness evidence like for CBT, for all those manuals? These are all CBT manuals. What are the effectiveness? And by the way, there's absolutely no difference between exploring feelings for anxiety and exploring feelings for anger, the red and the green book. There's no difference except for the word anger and anxiety and the color of the book. Okay? And I think that also speaks to this kind of transdiagnostic piece I was talking about. So, what do we know in terms of the evidence? There was an excellent systematic review recently published that looked at all cognitive therapy for people with autism across the life course for any type of issue, any type of focus. What did they come up with? They came out with 48 studies that looked at cognitive behavior therapy. They reported that there was actually a high risk of bias in those studies. And what does that mean? It means from a methodological perspective, those studies lacked some important things like clinicians being blinded to the treatment. So the clinicians might have been involved in the treatment. They knew who was getting the treatment and who wasn't. And then they were also involved in filling out the questionnaires about whether somebody improved or not, right? Or there was a lack of control or a lack of randomization. So, this group was they wanted to do the cognitive therapy, so we're measuring them, and these people didn't, and then we measured them, rather than randomly assigning. There's a whole bunch of different ways of ranking. The point is that there's still a lot of work we can do from a research perspective to get stronger in our design. But out of those 48, they found 24 that were using CBT for emotional difficulties, affective problems of some sort. The other 24 were using cognitive behavioral therapy and techniques to help with essentially social skills development or vocational training or other kind of outcomes. But 24 were around affective things. 17 of the 24 involved children or youth, so people under 18 years of age. 15 of the 24 were group-based. The other ones had were individualized. 19 of the 24 focused on anxiety specifically, right? And 14 of them were randomized controlled trials. So we've got this mix here. Overall, when they compiled these together, they found small to medium, what we call effect sizes, so small to medium kind of gains if you were participating in the treatment compared to these kind of controls or if you weren't involved in the treatment. Okay. When it came to being informed by the clinician, if you looked at clinician questionnaires or parents. What's interesting is there was no effect when they were looking at self-report, so the actual person participating in the trial. Okay. Now there's lots of reasons for that. We can talk about challenges with measurement, or if we're asking the right questions, or the experience from an individual's perspective as well. This is kind of what they're finding. I'm not going to go through all of this. Is from that paper. What was really interesting is they kind of looked at the effect sizes for all the studies they could find. So each kind of dot that you see, whether it's a green dot or a red dot, each dot is kind of and the farther it goes to the, to your right, the farther it goes to your right or my left was kind of the stronger the effect, so to speak. And you can see here, the important take home is that there was a lot of variability. That is, it wasn't everybody getting the same effect. Some studies had, some of the dots are farther right than others. And that kind of midline is kind of no effect at all. Okay, so some are really close to that line, some are on the line, and some are far away. And these are looking at different types of cognitive behavior therapy. And that's for either informant reports, so typically parents, or clinicians. So there's a lot of variability out there in terms of it. It's not a kind of all the same way. There's a lot of differences in terms of who's participating, in terms of the actual activities within it, the clinical skills of the therapists. Right? It does it work or doesn't it work anymore? We have to move beyond that to why does it work in some situations and not necessarily others. A few other take-homes for you around, this is just my kind of overall. My impression is that the vast majority of the studies and the content that exists are for youth 8 to 15 years of age. That's kind of my assessment. They do not involve, none of those studies really, or rarely do they involve people with autism who also have an intellectual disability. The vast majority do not. About half to maybe 70% show meaningful gains of some sort kind of in there. It also speaks to, in these kind of trials, there are a considerable group of participants who don't walk away benefiting based on the trial. And we know almost nothing about long-term maintenance. For all of the talk of CBT being evidence-based for anxiety, for example, in this population, you know, as a clinician, I know I've had people who have come in and they've done really well in the group or in the intervention, and I've been patting myself on the back. And then I get a phone call 2 years later. You know, it looks like I just graduated, but I've been around for a while. That joke used to work a lot better, unfortunately. But you know, I've had cases where families contact me 3 years later, 4 years later, after a very successful involvement in a treatment trial. And that participant has still now very high needs, is in crisis, needs additional support, something else has happened, or the anxiety has come back. So we really don't know about in this kind of research, of affecting long-term change. Maybe that short-term intervention isn't sufficient. Maybe focusing just on that child or that one target wasn't enough. I also want to recognize that the use of applied behavioral analysis to address kind of maladaptive behavior or challenging behaviors, there's a huge evidence base for this. If we want to think about where's the evidence, right? There's a huge evidence both for short and sometimes long-term gains with an individualized approach. So that's another literature that's typically not discussed when we think about cognitive behavioral therapy, though the processes certainly of behavior therapy and applied behavioral analysis, you know, if you look at some of the meta-analyses that exist now of what is evidence-based interventions for mental health problems, the work of Wong and others that have come out of the US, CBT is just one part of that, and they have a whole host of behavior therapy technologies or approaches within this kind of broader realm that are shown to be effective. So we've published, I'm not going to go through our studies, but we've been working on cognitive behavior therapy to address emotion regulation in kids with autism in a trial at York University, and showing very promising effects. So there's a randomized trial that we just finished and that we just unwrapped, and I'm happy to say that there are some meaningful changes that are happening for families. But again, it's still subject to many of those same limitations that I just talked about. So beyond that, is there other evidence? Well, there's growing evidence for mindfulness-based therapies. Now, I'm saying growing because we still need to know a lot more. A recent review came up with 6 studies that involved people with autism using mindfulness-based therapy. Only one of those was a randomized trial. 2 were multiple baseline designs, and the other 3 were kind of these more pilot pre-post. While they talk about how anxiety and thought problems might change for children using mindfulness-based therapy, or aggression and well-being and social responsiveness for teens, or even reduced anxiety, depression, and rumination in adults with autism who participate in mindfulness-based experiences here, a few things to note is that we know almost nothing about the clinical utility of this. And what I mean by that is that for the people who come in, and this is a picture of a mindfulness-based training that we did at our university. My experience has been is that when people come in for mindfulness-based therapy, things like John Kabat-Zinn's mindfulness-based stress reduction or mindfulness-based cognitive therapy and the like, those that participate in it, those that do it, really benefit. But it's really hard to participate in it, and it's really hard to do it. I kind of liken it to going to the gym. Right? If you go to the gym and you work with a trainer 1 day a week, which is kind of like coming to therapy, doing mindfulness-based therapy with me as a clinician, I'm your trainer 1 day a week. When you come and you participate in the session, it feels great, right? You leave feeling like, oh, I worked out, I feel so good, yeah. But then you don't do anything in between, right? You don't go to the gym until the next kind of training session. How much are you going to actually get physically healthy if we were talking about working out here, right? Or if you participate in the training with me for those 10 training sessions, and then afterwards it's done and you stop training and you stop working out. Right? And so that's the difference between something that might be efficacious, because when you're working out, when I'm getting you to do that stuff, it's helping. You're getting stronger, right? You're engaging your body in the right way, but it's really hard to maintain. Okay? Or it could be hard. Or maybe not everybody decides that it's right for them, or most people don't decide, this is not for me, I'm not going to train in this way. So we don't know much about that kind of fit. So the emerging literature shows that of the people who participate and of those that stick with it, it can be very helpful. But there's a big but. Okay? Now, that's not a bad thing, because why should we only have one kind of intervention for everybody? Right? Why shouldn't we have a menu of options and you get to pick the one that's best for you? So I do want to recognize, I'm not a psychiatrist, but I was curious as I was putting this together, let's not forget about the role of medication, right? In terms of mental health care in the general population as well as in autism. We have to recognize that if we're not talking about a one size, one kind of way approach, that there might be an important role to play in setting the stage, especially for other kind of work, for helping at a biological level, for equipping somebody using medication. I know many of the patients or clients that have participated in our trials, about half of them are taking some form of psychotropic medication, and they're participating in our trials. Right? And that could be a very important part of their care. Now, I did do a review of the literature for this talk and around medication, psychotropic medication use in autism. And this recent one found 47 studies, quite a lot of evidence, and suggested in the end that there was some evidence for what they called, quote, ASD-related irritability, which I'm not really sure exactly what that is, in children and teens. As well as ADHD medication for ADHD symptoms. Well, and that, if anybody here has ever taken ADHD medication, right, you'll focus better if you take, the stimulant medication typically as well. Like that, okay, so there's some evidence for that. But they know almost nothing around the use of, for example, antidepressants or other kinds of medications, or the polypharmacy that often can take place of having many medications at the same time. I'm not here to say medications aren't part of the answer here or part of the conversation, but what the literature seems to suggest is that more work needs to be done, and we need to have caution in how we kind of consider the use of medication.